Welcome back to the deep dive. Our bodies are run by this incredibly complex network of chemical messengers, hormones, right? This whole endocrine system, it has to work with, like perfect timing and balance,
Absolutely. And when that system sends out a distress signal, well, the stakes can be really high, demanding immediate clinical judgment.
which is exactly what we're diving into today, those signals.
That's right. When we look at a whole stack of lab results, clinical notes, all related to reproductive endocrinology, the first job isn't diagnosis, not really, it's triage.
Triage, meaning sorting out what's urgent from what's not.
Precisely. We have to instantly separate the noise, the benign variations that happen from the real urgent hormonal red flags. Our mission today really is to equip you, the listener, with the ability to spot those critical distinctions.
Okay, so how do you tell the difference between something that just needs watching versus something needing immediate action?
That's the goal. To know when it's simple monitoring versus needing, say, imaging or an intervention right away.
And we've got some pretty solid source material for this. A big collection of clinical notes covering diagnostics across all ages, both sexes. It's meant to give you a functional roadmap.
And to use that roadmap effectively, there are 3 key triage markers we need to get comfortable with right off the bat.
Okay, let's hear them.
We absolutely need to understand why DHEAS is the go-to marker for the adrenal gland, why the LH-BH ratio tells us so much about central control, the brain's role,
And the third?
and why a bone age assessment, just an X-ray, can instantly flag a risk to a child's final adult height.
Right. DHEAS, LHFSH ratio, bone age. Got it.
These 3 tools, they're really the foundation of endocrine triage. If you can look at those results, understand where they're coming from, adrenal, pituitary, gonads, you've honestly done like 80% of the initial diagnostic work.
So we're going to see how these numbers fit together.
Exactly. We'll show you how these seemingly isolated numbers actually build predictive flowcharts. So you know not just what the problem might be, but where it's starting and, crucially, how fast you need to act.
Okay, let's kick things off with kids. Pediatric hormonal issues. Because when a child shows early signs of puberty, the stakes are, well, they're incredibly high. Timing is everything for their final height.
It really is. The main challenge here is telling apart a benign, sort of self-limiting early start from a genuine pathology, something that threatens to shut down growth too soon.
Okay, so let's talk about premature adrenarche. You said this one is often benign.
Yes, it's a classic example. Causes a lot of parental worry, understandably, but it's usually benign. It's defined basically as the early onset but isolated onset of adrenal androgen production.
Adrenal androgen production, so what does that look like?
We're talking about things like pubic or axillary hair showing up early, maybe some acne, or even adult-like body odor. And by definition, it's precocious if this happens before age 8 in girls or age 9 in boys.
Okay, hold on. If a young child is getting pubic hair, that sounds like puberty starting. Why do we call this benign?
It all comes down to the source of the hormones. See, in adrenarche, it's just the adrenal gland maturing a bit early. Specifically, a part called the zona reticularis starts making androgens.
But it's only the adrenal gland.
Exactly. It's an independent process. It's not connected yet to the main reproductive axis, the HPG axis. We call it hypothalamic pituitary gonadal. That hasn't woken up yet.
So if the main system, the HPG axis, isn't active, what confirms clinically that this is just adrenarche? What are the signs or lack of signs?
Right. You see the hair, maybe the odor or acne, but you absolutely must not see the signs of real sex steroid exposure.
Meaning?
For girls, no breast development. That's called a blush. For boys, no testicular enlargement. That's key. And crucially, the lab work confirms the source.
Yeah, back to the labs.
Yes. Only the DHEAS, that's dehydroepiandrosterone sulfate, is mildly elevated. DHEAS is the adrenal-specific marker. The ovaries or tests don't make significant amounts of it. So high DHEAS, but normal estrogen and testosterone.
Okay, so if the main sex hormones, T and E, are normal, that means the growth plates aren't getting that strong signal to close early. Which brings us to that critical diagnostic marker you mentioned earlier.
The bone age. Absolutely crucial. We do a simple X-ray, usually of the left hand and wrist, and it estimates the skeleton's maturity.
And in premature adrenarche.
The bone age is normal. That means the child's skeletal development matches their actual age. This is the ultimate reassurance.
Why is it so reassuring?
Because it confirms there's no accelerated fusion of those growth plates, the epiphyses, no threat to their final adult height. If the bone age is normal, we've effectively ruled out the more serious things like central precocious puberty or CPP and congenital adrenal hyperplasia, CAH.
Okay, so short term, it's good news, just monitoring. But our sources mentioned this could be a warning sign for later, right? Especially for metabolic health.
Yes, it's actually a fascinating and kind of concerning metabolic foreshadowing, particularly for kids who are also dealing with obesity.
How does obesity play into it?
Well, premature adrenarche can sometimes be driven by hyperinsulinemia, high insulin levels. This often goes along with early obesity or insulin resistance, and high insulin can actually stimulate the adrenal gland to produce more androgens.
So it's a loop. Insulin resistance drives adrenal androgens.
It can be, yes. So while we're monitoring the child for, actual puberty starting, we're also keeping an eye out for future endocrine problems. The source material is quite clear. This variant significantly bumps up the risk later in life for PCOS, polycystic ovary syndrome, type 2 diabetes, and full-blown metabolic syndrome.
Wow. So managing it isn't just watching hair growth.
Not at all. It's recognizing potentially the very first sign of long-term systemic metabolic stress.
All right, now let's switch to the other side of the coin, the red flag condition. Central precocious puberty, or CPP. This isn't just an early variant. This is the whole system kicking into gear too soon.
Exactly. This is a full-scale, premature activation of the entire HPG axis hypothalamic pituitary gonadal. Think of it like the conductor in the brain, the hypothalamus, starting the orchestra way too early.
The hypothalamus sends out GnRH.
Right, gonadotropin-releasing hormone. That tells the pituitary, the musicians, to release LH and FSH, and those hormones then tell the gonads, the instruments, to start producing sex hormones like estrogen or testosterone.
So clinically, how does this full activation look different from that limited adrenarche we just discussed?
You see the whole picture of puberty, all the signs. It's often called isosexual precocity, meaning the signs match the child's biological sex.
Okay, so for girls.
Breast development and pubic hair.
And for boys.
Testicular enlargement. That's the first real sign the gonadotropins, LH, FSH, are working. Plus pubic hair. And here's the critical difference from adrenarche. You see a dramatic growth spurt and, most importantly, a significantly advanced bone age.
Let's drill down on that bone age again. You called it a battle for normal height. Why the dramatic description?
Because those high levels of sex steroids, the estrogen and testosterone that are now flooding the system early, they act directly on the growth plates in the bones. They accelerate the process of ossification or hardening and closing.
And if those plates close too early?
The child stops growing. They lose potentially years of normal height gain. That advanced bone age is the direct measure of this risk, the risk of reduced adult height. That's the immediate threat that makes CPP so urgent.
So how do we confirm it's definitely central activation, meaning it's coming from the brain or pituitary, not somewhere else?
We usually do a diagnostic test, often involving a GnRH agonist. We give a synthetic version of that hormone.
And see how the pituitary responds.
Exactly. If we give the agonist and see a big spike in LH and FSH, that confirms the pituitary is primed and ready to respond. It's gonadotropin dependent. The LH-FSH ratio often shifts too, favoring LH, confirming central activation.
Okay, so labs confirm CPP. What next?
Here's the major clinical decision point. Confirmed high LH-FSH in this context is an immediate, non-negotiable trigger for an MRI scan of the brain.
Wow, straight to brain imaging. Why?
Because, especially in younger kids, CPC isn't always just idiopathic, meaning we don't know the cause. Sometimes, maybe 10–20% of the time, or even higher in very young children, it's caused by an underlying lesion in the central nervous system.
Like what kind of lesion?
Things like a hypothalamic hamartoma, that's a benign tumor that can actually secrete GnRH itself, or maybe a craniopharyngioma or other tumors or cysts near the pituitary. Finding something like that completely changes the game.
How so?
Well, the management priority shifts instantly from just suppressing hormones to potentially needing neurosurgery or radiation to treat the underlying cause. You have to do the MRI before you commit a child to years of hormone suppression therapy.
Okay, that makes sense. And what if the MRI is clear? It comes back negative, confirming the CPP is idiopathic.
Then the goal becomes purely about preserving that final adult height.
And how do we do that?
We use long-acting GnRH agonist therapy. Medications like leuprolide, it seems counterintuitive, right? Giving more GnRH?
Yeah, why would you give more of the signal you're trying to stop?
Because continuous non-pulsatile administration of a GnRH analog actually downregulates the GnRH receptors on the pituitary. It essentially desensitizes the pituitary, shutting down the whole HPG axis.
Oh, okay, so it stops puberty progression.
Exactly. It halts puberty, slows down that rapid bone age advancement, and critically, it buys the child several more years of linear growth before their plates close, maximizes their final adult stature.
So being precise and telling apart the watch and premature adrenarche from the MRI now, central precocious puberty, is really fundamental.
Absolutely fundamental. It's a core skill in pediatric endocrinology.
Okay, moving from pediatric height battles to adult reproductive issues. Let's talk about hyperandrogenism in women excess male hormones. Our sources suggest a surprisingly clear way to triage this, and it all boils down to one thing.
Yeah, it really does. If there's one single principle I want listeners to grab from this section, it's this. The speed of symptom development is the single biggest clue to severity.
Speed, fast versus slow.
Exactly. We're trying to differentiate between, say, slow chronic syndromes like PCOS, which are common, and the incredibly rare but dangerous aggressive hormone production from a neoplasm, a tumor.
Okay, so let's lay out the rule of thumb right away. What's the crisis signal?
All right, here it is. Any woman presenting with hyperandrogenism that includes signs of frank virilization.
And by virilization, we mean more than just excess hair or acne.
Much more. We're talking significant changes like clitoromegaly, enlargement of the clitoris, temporal balding, hair loss at the temples, male pattern, a noticeable increase in muscle mass, or a deepening of the voice. If those signs develop rapidly, typically over weeks to months, definitely less than a year,
Okay.
you must assume it's an androgen-secreting ovarian or adrenal tumor until proven otherwise. Full stop.
That rap onset is the alarm bell.
It screams tumor. That speed indicates an overwhelming, unphysiological amount of androgen being pumped out, far beyond what you'd see in chronic conditions.
So the immediate next step is figuring out where it's coming from, ovary or adrenal.
Precisely. And this is where those specific lab pairs become absolutely critical. We need two key hormones.
Let me guess. Testosterone and DHEAS.
You got it. Total testosterone T and DHEAS.
Why those two specifically?
Because total testosterone can come from both the ovary and the adrenal gland. But DHEAS, remember, is almost exclusively from the adrenal cortex, that zona reticularis again. So these two labs act like a fingerprint to separate the source.
Okay, walk us through the results. What if we see really high total testosterone, like way high, maybe over 200 NGDL, but the DHEAS level is normal?
That pattern points directly to an ovarian pair. Classic fingerprint, typically something like a Sertoli-Leydig cell tumor. It's churning out testosterone like crazy, but the adrenal gland isn't involved, hence the normal DHEAS.
Okay, and the flip side, what if we see a markedly elevated DHEAS, maybe over 700 micrograms DL? The testosterone is also high.
That super high DHEAS is the red flag waving frantically for an adrenal tumor. Could be an adrenal carcinoma, maybe an adenoma. The adrenal gland itself is the source of the excess androgens.
Why is the testosterone high too then?
Because DHEAS itself is a weak androgen, but it gets converted in the body peripherally into more potent androgens like testosterone.
Yeah.
So T is high, but the sky-high DHEAS tells you the origin is adrenal.
Now, the sources really emphasize doing labs before imaging. Why is that sequence so important? Why not just get a CT scan right away?
It's about avoiding misleading information. If you jump straight to imaging, you might find what we call an incidentaloma, a small, benign cyst on the ovary, or a non-functional little nodule on the adrenal gland that has nothing to do with the symptoms.
Red herring.
Exactly. But if you do the hormones first, you know the source. High T, normal DAPAS, focus imaging on the ovaries, probably ultrasound first. High DHEAS, focus imaging on the adrenal glands, CT or MRI. The hormones direct the imaging precisely.
Makes sense. Okay, one last detail on the adrenal tumor profile. If the adrenal gland is pumping out all these androgens, what happens to the pituitary signals, like LH?
Great question. That massive flood of androgens, and some estrogens they might convert to, creates powerful negative feedback up to the pituitary gland. It tells the pituitary, whoa, too much hormone down here, shut down the signal.
So LH levels would be?
But suppressed. Low LH. So the full classic hormonal picture for a suspected adrenal androgen-secreting tumor is sky-high DHEAS, high testosterone, and low or suppressed LH. That feedback pattern is very different from what we see in chronic syndromes.
Which brings us perfectly to the most common cause of hyperandrogenism, polycystic ovary syndrome, or PCOS. And the key difference here is timeline, right?
Absolutely. PCOS is defined by its chronic and gradual progression. Symptoms often start around puberty and develop slowly over years. That immediately sets it apart from the rapid onset of a tumor.
And it's really common, isn't it?
It's the most common endocrine disorder in women of reproductive age. Estimates vary, but maybe affects up to 10% of that population. It's typically defined by the Rotterdam criteria needing 2 out of 3 things.
Right.
1, hyperandrogenism, either clinically obvious like hirsutism or seen on labs. 2, ovulatory dysfunction, meaning irregular periods, infrequent periods, oligomenorrhea, or no periods, amenorrhea. And 3, polycystic appearing ovaries on ultrasound.
Okay. What's the underlying mechanism? What's actually causing the excess androgens in PCOS?
It's complex, but a core feature is often a functional imbalance at the pituitary level, frequently resulting in an elevated LH-FSH ratio. That relatively high LH pushes the Kappa cells in the ovarian follicles to make more androgens.
And insulin resistance plays a role too.
A huge role. Insulin resistance is very common in PCOS, maybe 70% of cases, especially with obesity. High insulin levels can directly stimulate the ovaries and the adrenals to produce more androgens. It's a synergistic effect. The result is this slow, steady, mild to moderate androgen excess.
We often hear about the cosmetic aspects, the hair, the acne, but you mentioned earlier the real hidden danger, the big long-term risk is linked to the irregular cycles.
Yes, absolutely. The chronic anovulation, not ovulating regularly, that's the major cancer risk factor we worry about.
How does not ovulating lead to cancer risk?
When a woman doesn't ovulate, her ovary doesn't produce progesterone in the second half of the cycle. Progesterone is needed to stabilize the uterine lining, the endometrium, and prepare it for shedding during a period. Without progesterone, the lining keeps building up.
And there's unopposed estrogen involved too.
Correct. Those excess androgens floating around get converted into estrogen, specifically estrone, in fat tissue. So you have this constant estrogen stimulation of the endometrium, but without the balancing effect of progesterone. It's called unopposed estrogen.
And that constant stimulation is bad for the lining.
Very bad over time. It causes the endometrium to thicken and proliferate abnormally. This is called endometrial hyperplasia, and it significantly increases the lifetime risk of developing endometrial cancer.
Wow. So managing the cycle isn't just for convenience, it's actually cancer prevention.
It is absolutely cancer prevention. It's a primary life-saving goal in managing PCOS, totally separate from treating hirsutism or acne.
Okay. Now, given that strong link between PCOS, obesity, and insulin resistance, what's the best way to screen for diabetes risk? Is fasting glucose enough?
Fasting glucose and even HbA1c can miss early problems. The source material consistently points to the oral glucose tolerance test, OGTT, as the most sensitive screening tool.
The OGTT, the one where you drink the sugary drink.
That's the one. It measures how your body handles a glucose load over a couple of hours. It's much better at picking up impaired glucose tolerance or undiagnosed type 2 diabetes in women with PCOS compared to just fasting levels. It catches the metabolic risk earlier.
So wrapping up PCOS management, key goals are cycle regulation for that cancer risk and managing the metabolic side.
Exactly. For cycle regulation and endometrial protection, the standard first-line treatment is usually combined oral contraceptive pills, OCPs. The progestin in the pill protects the endometrium, forces a regular bleed, and the estrogen helps suppress LH, which lowers androgen production.
And fertility is the goal.
For women trying to conceive, OCPs are obviously out. The first-line treatment for ovulation induction has largely shifted to letrozole, which is an aromatase inhibitor. It works differently, but is often more effective than the older drug, clomiphene, for inducing ovulation in PCOS.
All right, let's pivot completely now to male endocrinology. Similar triage challenges here. When a man comes in with symptoms of low testosterone, we call that hypogonadism, things like fatigue, low libido, erectile dysfunction. The first question is, where's the problem?
Right. Is it the testes themselves failing? That's primary hypogonadism. Or is it a signaling problem from the brain, the hypothalamus or pituitary? That's secondary hypogonadism.
And sometimes the most urgent clues aren't even the main symptoms, but other physical changes like breast tissue development, gynecomastia.
Exactly. That can be a major red flag. Hashtag tag 3.1, unpacking secondary hypogonadism. Low T plus low normal LH-FSH.
So let's start with secondary hypogonadism. How do we identify that pattern?
Secondary hypogonadism is defined by the lab pattern. You see low testosterone, but the pituitary hormones, LH and FSH, are inappropriately low or maybe normal. They should be high if the testes weren't working, trying to stimulate them.
So the signal chain is broken higher up.
Precisely. The testes aren't getting enough stimulation from the pituitary. This pattern immediately tells you to look outside the gonads. Think hypothalamus, pituitary, or maybe some systemic issue affecting them.
Okay. And our sources point out three really interesting, maybe unexpected systemic causes for this exact pattern.
Oh, yeah.
Let's start with one that's becoming more common: opioid-induced hypogonadism.
Yes, with the rise in chronic opioid use for pain management, we see this more often. Opioids, unfortunately, have a pretty direct suppressive effect on the endocrine system.
How do they do that?
They act on specific receptors, mu receptors, in the hypothalamus, and this action strongly inhibits the normal pulsatile release of GnRH.
Back to GnRH, the master signal.
Right. If you suppress GnRH pulses, the pituitary doesn't release enough LH and FSH. No signal down to the testes means the Leydig cells slow down or stop making testosterone.
So the lab pattern is classic secondary: low T, low LH, FSH. What are the typical symptoms?
You see the usual suspects: low libido, fatigue, ED. Physically, the testes might feel small and soft because they're not being stimulated. But here's a key differentiator.
Yes.
Unlike primary hypogonadism, where the testes fail and high LH can sometimes drive estrogen production leading to breast growth, opioid-induced hypogonadism usually presents without significant gynecomastia. Seeing that combo, low T symptoms, small tests, but no gynecomastia, should make you immediately ask about chronic opioid use.
Good tip. Okay, second cause. Something rarer but very systemic: hereditary hemochromatosis. Iron overload causing endocrine failure.
Yeah, this is a fascinating example of a systemic disease hitting the reproductive hormones first. Hemochromatosis is a genetic condition, usually an HFE gene mutation, causing the body to absorb way too much iron from the diet.
And where does the iron go?
It deposits everywhere, unfortunately. Liver, pancreas, heart, joints. And critically for this discussion, it deposits in the pituitary gland.
What does iron do to the pituitary?
It's toxic. It essentially poisons and destroys the specific pituitary cells, the gonadotrophs, that are responsible for making and releasing LH and FSH.
So the pituitary fails because of iron. What's the classic clinical picture that screams hemochromatosis?
There's a well-known clinical triad, sometimes called bronze diabetes. It consists of 1, hypogonadism, which is secondary because the pituitary is damaged, leading to ED, low libido, testicular atrophy.
Okay.
2, diabetes mellitus, because iron also deposits in the pancreas and damages the insulin-producing cells.
And 3.
And 3, hepatomegaly or cirrhosis due to iron accumulation in the liver. Sometimes the skin gets a bronze or grayish tint, too. Seeing that combination, especially hypogonadism plus liver issues or diabetes, is a major clue.
And the workup then is?
Immediate iron studies. Check serum ferritin and transferrin saturation. They'll be very high if it's hemochromatosis.
All right. And the third systemic cause of secondary hypogonadism: severe liver disease itself, cirrhosis. This messes things up in multiple ways, doesn't it?
It really does. Cirrhosis hits male hormones from a couple of angles. First, think about protein synthesis. The liver makes most of our body's binding proteins, including thyroxine-binding globulin, TBG, for thyroid hormone, and sex hormone-binding globulin, SHBG, for testosterone and estrogen.
So if the liver fails, protein synthesis drops.
Exactly. Less TBG, less SHBG. The source material actually highlights the thyroid effect first. Because there's less TBG, the total T3 and total T4 levels might look low on labs. But the TSH and free T4 are usually normal, meaning the person is actually euthyroid. Their thyroid function is okay at the tissue level. It's just a binding protein issue.
Okay, but how does cirrhosis affect the sex hormones directly? The T to E ratio.
This is the second major hit. A cirrhotic liver can't clear hormones properly, especially estrogen. Estradiol levels rise. At the same time, testosterone clearance might be affected, but more importantly, the sick liver changes enzyme activity throughout the body, leading to increased peripheral aromatization.
Aromatization that's converting androgens into estrogens.
Exactly. So you get less effective testosterone production maybe, and more of whatever testosterone is around gets converted into estrogen. The net result is often low testosterone combined with relatively high estradiol. This high estrogen to androgen ratio is what causes those classic signs you see in advanced liver disease.
Sure.
Gynecomastia, significant testicular atrophy, spider angiomas on the skin, loss of body hair. It's the hormone imbalance driven by liver failure. Hashtag tag 3.2, the gynecomastia red flags. When is a mass cancer?
Okay, you mentioned gynecomastia, male breast enlargement. It's common, right? Puberty, aging, cirrhosis, medications, lots of causes. But sometimes it's not benign. What are the red flags for cancer?
This is critical. We have to rely heavily on the physical exam to sort this out. Benign gynecomastia, no matter the cause, is almost always symmetric, meaning both sides, Soft or rubbery to feel, bilateral, and located centrally right under the areola. It feels like a smooth, movable disc.
Okay, soft, symmetric, central. What features suggest malignancy instead? What makes you worried?
Cancer is different. Male breast cancer typically presents as a firm or hard lump, usually unilateral, one side only, often eccentric, meaning it's not perfectly centered under the nipple, maybe off to one side.
Any other signs?
Yes, you might see secondary changes like skin dimpling or puckering over the lump, nipple retraction, pulling inward, ulceration of the skin, or even bloody nipple discharge. Any of those features are major red flags.
And if you find those red flags?
Immediate imaging. First step is usually mammography and or ultrasound of the breast. You cannot assume it's benign gynecomastia if those features are present. You have to rule out cancer first.
Got it. Now, our sources mention two specific conditions that dramatically increase a man's risk for breast cancer. First one, Klinefelter syndrome.
Right, Klinefelter syndrome, the 47,000 XXY karyotype. It's actually the most common genetic cause of primary hypogonadism. The testes just don't develop or function properly from the start.
So low testosterone.
Yes, low testosterone production by the testes. But the pituitary sees this and cranks up the signal, so you get very high LH and FSH.
How does that lead to breast cancer risk?
That chronically high LH-FSH stimulation hammers the remaining testicular tissue, including Leydig cells and surrounding stromal cells. This dramatically increases the activity of the enzyme aromatase within the testes and periphery.
So more conversion of androgens to estrogens again?
A lot more. They end up with a persistently high estrogen to androgen ratio. This hormonal environment causes significant, often severe, chronic gynecomastia. And crucially, it increases their lifetime risk of developing male breast cancer by something like 20 to 50 times compared to XY males. It's a major risk factor.
Wow. Okay, the second urgent scenario involves a tumor in the testes, a germ cell tumor, but presenting first with breast changes. How does a testicular tumor cause gynecomastia?
This is a really important time-sensitive diagnosis. It's driven by a specific hormone produced by certain testicular tumors. Beta-HCG, human chorionic gonadotropin.
Isn't that the pregnancy hormone?
It is, but certain testicular germ cell tumors, especially choriocarcinomas or mixed tumors with choriocarcinoma elements, can produce massive amounts of beta-HCG.
And what does beta-HCG do in men?
Beta-HCG is structurally very similar to LH. It can actually bind to and activate the LH receptors on the Leydig cells in the testes.
So it stimulates the testes like LH would.
Exactly, but often much more strongly. This leads to increased androgen production. But here's the twist. That intense stimulation also cranks up aromatase activity within the testes. So you get a rapid, dramatic conversion of those newly made androgens into potent estrogens.
Leading to rapid gynecomastia.
Yes. Often very rapid and sometimes painful gynecomastia, driven by suddenly high estrogen levels originating from the HCG-stimulated testes.
So if you see a man with rapidly developing gynecomastia and you check labs and find a markedly elevated beta-HCG level,
that is a tumor marker until proven otherwise. You have to assume it's coming from a testicular germ cell tumor.
even if the testes feel normal on exam.
Absolutely. The primary tumor might be very small, non-palpable, or burned out even. The hormonal signal, the high beta-HCG causing the gynecomastia, is the critical finding. The mandatory next step is an urgent testicular ultrasound to find that primary tumor. It's a potential oncologic emergency.
Okay, we've really hammered home how knowing the right lab pair or the right physical sign can instantly help triage things. Let's wrap up with 2 sections focusing purely on nailing the diagnostic sequences and avoiding common medication pitfalls. Hashtag tag 4.1 workup flow for secondary amenorrhea.
Right. Let's take secondary amenorrhea. Super common presentation in clinics. It just means menstruation has stopped for at least 3 months if cycles were previously regular, or 6 months if they were irregular. You need a strict, logical approach here.
And there's one step that comes before any fancy hormone testing, right?
Yeah.
Seems basic, but crucial.
Absolutely non-negotiable first step. Rule out pregnancy. You need a sensitive HCG test always. Always first. You simply cannot interpret endocrine labs for amenorrhea if the woman might be pregnant.
Okay, pregnancy test is negative. What's next? What are the key initial labs?
Once pregnancy is excluded, you order the big 3 initial screening labs that really guide the rest of the workup. TSH, prolactin, and FSH.
TSH for thyroid, prolactin for pituitary issues, FSH for ovarian function. Why these 3 specifically? How do they act like a compass?
Because the results immediately point you in the right direction. Let's break it down. 1. If the TSH comes back abnormal, high or low, you investigate and treat thyroid disease first. Both hypo and hyperthyroidism can mess up menstrual cycles.
Makes sense. Address the thyroid first.
2. If prolactin is elevated hyperprolactinemia, this often suppresses GnRH release from the hypothalamus, stopping cycles. A high prolactin mandates an MRI of the pituitary gland to look for a prolactinoma, a benign pituitary tumor that secretes prolactin.
Okay, hyperlactin means pituitary imaging.
3. If FSH is elevated, especially if it's high along with low estrogen levels, that points towards the ovaries failing. This is called primary ovarian insufficiency, or POI, if it happens before age 40. A confirmed high FSH in that context then requires a karyotype analysis.
Why a karyotype? Checking chromosomes.
Yes, to look for underlying genetic causes like Turner syndrome mosaicism, where some cells are 45X, or fragile X premutations, which can be associated with POI.
So those three labs, TSH, prolactin, FSH, really branch the investigation effectively. What if they all come back normal?
If TSH, prolactin, and FSH are all within normal limits, then you start thinking about other causes. Maybe hypothalamic amenorrhea, often related to stress, excessive exercise, significant weight loss, or maybe it's related to androgen excess, like PCOS, which we discussed.
So then you might do a progesterone challenge or check androgen levels.
Exactly. But the beauty of that initial TSH, prolactin, FSH screen is that it quickly tells you if the primary problem lies with the thyroid, the pituitary, or the ovary, making the subsequent workup much more targeted and efficient. Hashtag 4.2, the medication interaction nugget.
Perfect. Okay, last piece.
Yeah.
A really common medication interaction. We talk a lot about the HPG axis, but let's not forget the thyroid axis, specifically oral estrogen and levothyroxine. This seems like something easy to miss.
It is, and it can cause unnecessary symptoms for patients on thyroid replacement. It's a classic pharmacodynamic interaction based on protein binding.
Okay, lay it out. What's the core mechanism?
It's pretty straightforward. Oral estrogen therapy, whether it's in combined OCPs or postmenopausal hormone replacement therapy, HRP, has a significant effect on the liver. It tells the liver to produce more thyroxine-binding globulin, or TBG.
TBG, that's the main protein that carries thyroid hormone, T4, in the blood, right? Like little taxi cabs for T4.
Exactly like taxicabs. So if you suddenly put a lot more empty taxicabs, TBG molecules, into the bloodstream,
They start picking up the available passengers, the free T4.
precisely, more TBG binds more of the free active T4 hormone. This causes a temporary drop in the level of free T4.
What happens then?
In someone with a healthy thyroid gland, the pituitary senses that dip in free T4. It responds by increasing TSH secretion. The thyroid gland then gets the message and produces a bit more T4 to fill up those extra TBG cabs until a new, slightly higher total T4 level is reached, but the free T4 level returns to normal. The system compensates.
Okay, but what about a patient who doesn't have a working thyroid, someone who's hypothyroid and relying entirely on their daily levothyroxine pill?
They cannot compensate. Their thyroid gland can't respond to that TSH signal by making more T4. They only have the T4 they took in their pill that morning.
So when they start oral estrogen, the new TBG binds up their dose.
Correct. It binds a larger fraction of their fixed levothyroxine dose, causing their free T4 level to drop below their target range. Their TSH level will then rise, and they'll likely start experiencing hypothyroid symptoms again: fatigue, weight gain, cold intolerance, brain fog.
So the clinical takeaway is crucial here.
Absolutely critical. If you are initiating oral estrogen therapy, OCPs or HRT, in a patient who is already on a stable dose of levothyroxine for hypothyroidism, you almost always need to increase their levothyroxine dose preemptively.
By how much, typically?
Often by about 25% or so, but it needs monitoring. The goal is to provide enough extra T4 to saturate that newly increased TBG pool, thereby maintaining their free T4 level in the therapeutic range and keeping their TSH stable. You have to anticipate this interaction. Hashtag tag outro.
Wow, this has been a deep dive indeed. I think it really confirms that in reproductive endocrinology, maybe more than other fields, clinical skill isn't just knowing the diseases, it's about knowing which specific pair of lab tests or which subtle sign gives you the most diagnostic leverage right away.
That's exactly right. We've tried to build a framework that prioritizes that triage. We've moved beyond just defining conditions. We now know the timeline, fast versus slow, is huge for telling tumors from syndromes.
And we know specific markers like DHEAS or bone age aren't just numbers, they're immediate decision points about urgency.
Right. Does this kid need an MRI now? Does this man need a testicular ultrasound stat? Knowing when to escalate based on specific findings is key. It's about focused, evidence-based action.
It really empowers you to make the right first move.
And looking back at our discussion on secondary hypogonadism, it's striking how often the reproductive axis acts like an early warning system for major systemic problems.
Like with hemochromatosis and cirrhosis, diseases damaging the liver or causing iron overload, but they show up first as low TED gynecomastia problems in the pituitary gonads.
Exactly. The reproductive hormones are exquisitely sensitive to systemic health.
Which leaves us with a really interesting final thought for you, our listener, to ponder. We saw the reproductive system basically monitoring for things as serious as iron overload and liver failure. So what other common systemic stresses, maybe things like chronic inflammation, maybe specific vitamin or mineral deficiencies, maybe even chronic psychological stress, could also be subtly shifting our reproductive hormone levels, like the LH-FSH ratio or sex hormone balance, long before they cause more obvious disease elsewhere?
It's a fascinating question. Could our reproductive hormones be acting as silent sentinels for other aspects of our overall health? Something to think about.
Definitely something to explore. Join us next time for another deep dive.